Yeah, greetings from Dr. Shankar Nayak. Today we are going to do microablation of a solid cystic nodule of thyroid. We use a eco microwave machine. So we have a generator, antenna, and coolant system. So before that, beginners, we have to see the a 3D structure of the thyroid nodule. What is 3D structure? You have to see the medial border, inferior border, lateral border, and superior border. So how to handle the ultrasound probe and the antenna? That is a technique called threshold technique we use. So for that, we can clearly see the 3D structure. We clearly ablate all the 360 degrees of a 3D structure of the solid thyroid nodule. So we follow a technique called a threshold technique. So for that you can come to inferior to superior and medial to lateral and superior to the medial and inferior. So we will follow the 3D structure and for the complete ablation of the nodule, this technique. And ergonomics, you can simply use the dental chair, simply sitting behind the head of the patient. Right side you can use the antenna with the left hand, and left side nodule you can use the right side opposite. So for we use always we do in local anesthesia. For local anesthesia, we give a 10 ml 2% lignocaine in between the strap muscle and false capsule. That is called perithyroid lidocaine injection. So we give exactly because there is a sensory nerve supply. So that's local anesthesia beauty of this, because we can monitor vocal cords. Intermittently we can check the vocal cords by the local anesthesia. That is the advantage. If anything goes wrong, like a recurrent lar injury, you can go for risk. You can protect the recurrent lar injury. Now, next we go for hydrodissection. What is hydrodissection? Installation of the colloid solution. A 30 to 40 ml of colloid solution, like the voluven expansion. You can use the medial compartment and lateral. So we do two compartment. Mainly hydrodissection is a key role in the protection of the peripheral structure. So nerves, mainly especially recurrent laryngeal nerve, vagus nerve, and medial sympathetic ganglion. So you see now the how it is giving a above trachea, pretracheal fascia, medial side, dangerous triangle. In between trachea esophageal groove, dangerous triangle, you are injecting the colloid fluid. This will be protect. So coming to the ablation technique, we follow moving shot, trans-systemic approach by layer, layer by point, and point to layer, making all slides and layer by layer. So this is a solid cystic nodule. You see the solid cystic nodule, and this amount is a solid cystic, and this is solid. So prior you can aspirate, but it causes intracystic hemorrhage. That's very recurrent problem. Abscess, intracystic hemorrhage, and it is difficult. So what we prefer is around cystic nodule will ablate first. Will ablate, will cause the ischemia. All the vessels, bleeding vessels or feeding vessels will ablate. So this is the new technique we do. First we ablate around the cystic nodule. What I am doing is just, you see I am just doing the ablation around the cystic nodule. You try to understand. And so then with interstitial hemorrhage cannot form. And sometimes it's a bigger nodule, we use 30 to 40 watts. So power setting is a moving shot, 40 watts in sometimes, but we regularly use 30 watts. Okay. So after this, when you cystic nodule you are ablated completely, then you plan for say aspiration. You see, after ablation you can see the will plan ablation moving shot by technique we call 10 second 10 second 10 second, multiple shots, layer by layer we are ablating moving shot technique. So for this is because this video making because for radiologist, intervention radiologist, ENT surgeon, endocrine surgeon, and a general surgeon, those you can practice with a MDT, multidisciplinary team. So because other countries all these are practicing. So now you see that there is some cyst is there. So this cyst we are aspirating. So you see the aspirating where, so from the 18 gauge needle We are spinal lead 18 gauge. You see this, there is a colloid material is coming. We are aspirating cystic this. Okay. After that, so after aspiration, you can plan a advanced technique called zigzag moving shot technique from the inferior border to the superior, layer by layer, slicing layer. So it covers a 3D structure. It covers the all the borders, and it cannot remain any leftover tissue. You should follow this technique. A zigzag maneuver means, say for example, if a nodule is there, go inferior border, ablation zone, next ablation zone, next ablation zone, making slice and ablation zone, one border, second border, and all borders. So this zigzag movement have a less recurrence, have a less regrowth. That will complete a 360 degrees, all angle, all borders, all direction. So there is a new concept, a new technique called a zigzag maneuver technique, and it have a good efficacy, good effective monitoring. You can see this. This is a white gasification. You are observing this. This is antenna moving white gasification because of a microwave act on the cells that act on the water molecule. It disrupts up the water molecule, cause two negative hydrogen atoms and one positive oxygen atoms, cause frictional heat, cause cell death. So we prefer here moving shot. Meaning of moving shot technique 10 second, because we are causing cell death below 85 temperature. Okay, we are this microwaves giving 85 temperature. This 85 temperature will cause coagulative necrosis. Once moving shot, this is a smooth firing, moving firing, not 1 point more than 1 minute. If you give more than 1 minute, it causes the cell death, but causes carbonization. If tissue temperature is high, above 100, 120, it causes carbonization. Carbonization will cause the infection and no phagocytosis, no apoptosis. That will cause the pain and infected. So it cannot be phagocytosis. So that is reason the moving shot technique we follow. That is the reason we do a moving shot zigzag maneuver, complete ablation of the nodule, solid and cystic nodule. This maneuver will easily can do any surgeons, any endocrinologist, any endocrine surgeon, ENT surgeon. With the help of radiologist, we can multidisciplinary team can practice. It's a very easy compared to surgical wise. We save thyroid gland. The here it's we are save thyroid gland, because we are not ablating normal tissue, we are ablating only pathology tissue here. So the rest of thyroid nodule, it works, it releases hormone. So patient cannot be in hypothyroid in future. Try to understand. That is the beauty of the microwave ablation. Okay, so that is the reason that everybody is practicing in other countries. Everybody, because a simple local anesthesia daycare procedure, unnecessarily you can avoid all surgical complications. So this is even the complications very minimal. So protection now is very easy here, and it is easy to daycare surgery. So I request all the surgeon can practice. Okay, and moreover here you can see how the angulation between the transducer, ultrasound probe, and the antenna. So you can plan this completely. It is not a blind procedure, right? It is under vision procedure. So here you can see the carotid artery, carotid sheath, and there is a fluid. It is called the hydrodissection. At least hydrodissection. So this will stop the barrier, the heat to the opposite lateral structure. So after that, you can do the contrast or you can do the color Doppler. You can see how the effect is there. So Doppler we do because any residual or leftover, any missed ablated, non-ablated area. So you see that there is a missed superior border, non-ablated area. We are planning again. We are giving second shot of this ablation. This is called supplementary ablation. So this is the Doppler useful. Sometimes you can do contrast also. So this is very efficient in worldwide. Eco company is doing lot of academic training program, hands-on training, and we have done more than 120 cases. We have got excellent results, excellent result, cosmetic wise, pain wise, and the recovery wise. I request all the doctors to practice. Thank you very much.